May I now call upon Dr. Nilotpal Behuria for his presentation on Association of Carotid or Aortic Disease in Coronary Artery Bypass Surgery and Impact on Neurocognitive Outcome, a prospective observational study.
Morning, sirs. I'll be presenting a prospective observational study on the association of carotid and aortic disease in the coronary artery bypass surgery and its impact on neurocognitive outcome. Just a brief introduction. The incidence of neurological complications following CABG range from 1 to 4.3%. Stroke is one of the most feared complications. The perioperative stroke definition is within 30 days post-op, and generally they occur after the surgery. And the role of carotid and cerebral artery disease in this is the extracranial internal carotid artery disease is one of the major risk factors for neurocomplications, and intracranial atherosclerosis is also one of the leading cause of ischemic stroke in widespread vascular disease. Coming to the screening and assessment, one of the most important methods is the carotid duplex ultrasound. It has a good sensitivity and specificity. It has the features to observe the plaque, echogenicity, ulceration size, which tell us an stroke risk. There are two other methods of assessing. One is CT aortography and another is intraoperative TE, which give an assessment of the calcification. So in summary, now coming to my aims and objectives, the studying association of the carotid artery and ascending aorta disease in patients undergoing CABG and studying its impact in post-operative neurocognitive outcomes. So it was a prospective observational study of 1.5 years from August 2023 to 2025, and a total of 122 patients were included. Inclusion criteria: all patients undergoing coronary artery bypass grafting, and exclusion criteria: there is with patients with previous neurological disease or dysfunction, or with severe liver, kidney and other metabolic dysfunction leading to encephalopathies, on pump coronary artery bypass grafting cases, and redo surgeries. So after due approval of the Institutional Ethics Committee, the patients were observed in both pre-operative, perioperative and post-operative period, and appropriate statistical methods were utilized to reach the conclusion. So like as I said previously, carotid artery Doppler, CT aortogram and TE were used. For carotid artery Doppler, these were the parameters mainly used for diagnosis of the stenosis, and patients were graded into three varieties: mild, moderate and severe. Mild is less than 50% stenosis, moderate is 50 to 69 and more than 70% is severe. And this is the CATS grading for TE atheroma grading. Point important here is grade 4, grade 5 are generally high risk factors. And so neurocognitive, they were divided into major and minor, and for the major neurocognitive defects, CT or MRI was done, and for assessment purpose, mini-mental state examination and BVRT, Benton Visual Retention Test, were used. So coming to the results quickly, most of the patients were in the age group of 50 to 70, and most of the patients were male. Majority of them had triple vessel disease, and 29 out of 122 patients had carotid artery stenosis, some form of carotid artery stenosis. 9 patients had mild, 9 patients were moderate, and 11 patients had severe disease. These are the major risk factors in these patients. And coming to the final neurological outcome part, 8 out of 122 patients had neurological consequences, 7 had severe carotid stenosis, and most of the neurological consequences occurred in the age group of 60 to 69. And as you can see from this figure, bilateral stenosis had more neurological outcome, and same here, bilateral having more neurological outcomes. This bilateral also having statistically significant neurological outcome. And coming to deaths, although we had very deaths per se with neurological outcome were very rare, so it was not very significant. NCCT chest in terms of predicting carotid stenosis, we had around 16 patients with carotid stenosis, which NCCT plate positive was 8, so it was not very much this thing. And coming to the intervention, only 3 patients with severe carotid stenosis underwent pre-op embolic protection device, and 6 patients out of 29 patients with some form of carotid stenosis underwent total arterial CABG, and none had neurocognitive outcomes. So to conclude, carotid artery screening with NCCT chest and TE may be a shot in the arm, but due to resource constraints, if carotid Doppler and TE are definitely recommended, but NCCT chest can be done if resource constraint doesn't limit it. Thank you.
Thank you. Among these patients,
Sir.
how many had proximals on the aorta? Did you compare between those who had the anaortic?
Sir, actually, because of the surgeon's prerogatives, means people doing total arterial and people doing venous, so we out of the 122 patients, we had 32 total arterial, but people with some form of carotid stenosis, it was 29. Only 6 patients had total arterial CABG, sir.
Did you compare these patients who had a proximal on the aorta, those who had total arterial?
Yes, sir. That is why I had mentioned here. Out of these 6 patients, nobody had neurocognitive outcomes, sir. But this means that doesn't mean that out of the 29 patients who had some form of carotid stenosis, all didn't undergo total arterial CABG, sir.
Did you really screen only Doppler? You thought about getting a neck vessel angiogram, or just NCCT, we would not give you a vertical slice, it would only give you a transverse slide. You thought that was good enough for you?
Sir, actually carotid Doppler was done and NCCT was done. NCCT, like I showed in my slide, because of paucity of time I couldn't explain, because there were 16 patients with carotid stenosis, but only 8 patients in NCCT chest, because we get generally normal reports in NCCT here.
Actually, in this cases, do you just scan all the patients for the carotid stenosis?
Yes, sir. Yes, sir. It was a
all the preoperative patients.
Yes, sir. Since it was a study, it's a prospective study, so all potential patients
in the hospital.
Yes, sir. Yes, sir. Getting it in-house only, sir. All the reports were in-house, because it's a prospective study. So patients were enrolled and taken, sir.
But so still, this incidence of this CVA is less with the CABGs even in the presence of the carotid stenosis, because you know what? Because this statins, they just stabilize the flux in the carotids. Previously, before the statin started, it was quite high.
Yes, sir.
And now it is because the flux are stable. Okay.
One question to you: why did you exclude the on-pump CABG? You had an exclusion criteria, you excluded the on-pump CABG.
Yes,
why?
sir. Yes, sir. Sir, because on pump, the neurocognitive pump itself also has lot of neurocognitive outcomes, so it will be a confounding factor. So before planning this study, this was dwelt upon, and that is why it was excluded, sir.
Thank you.
Thank you, sir.